Okay. Promoting for the government. Why do prenatal diagnosis is important? Why do we do prenatal diagnosis of heart disease? First of all, we have here a ventricle, we have two atria, and we have also color. So I don't recommend doing it for the heart for a general obstetrician or somebody who's in a very busy clinic. No, we do the 2D, but 2D of the 3D, you can always add to it, and because you can see the depth of the ventricles and the anatomy in a better view. But 2D, two-dimensional echo that we want, not the 3D. And also, this is the message from me as a cardiologist. It's going to change gears here, try to attract your attention to get more of what we're doing today. So 23 years old, primary gravida, 23 years with gestation, referred to cardiomegaly on routine anomaly scan. Anomaly scan usually 18 to 22 weeks, or it's called also anatomic scan. So what we try here is that you have proper ratio, the 4-chambered in the chest, and then this should be 1/3 of the big area, and so this is normal. Here this is 1/3. So before you refer, you can get the ratios. If you're suspicious, like if it is 50% for cardiomegaly, just to take you to the normal, this is 4-chamber view, this is ventricular septum, and this is right ventricle because that is more towards the apex, and because there is also moderator band. Okay, the aorta, this is interrupted aortic arch. It's not going into like that, it's going up there like, okay? So this is one of the cases that we scanned. And it's very easy to diagnose a hypoplastic, either left or right, because one of the ventricles will be bigger than the other. So this is the asymmetry before you do anything, and then you transfer to the fetal cardiologist. So here, one ventricle, two ventricles, okay, they're not the same, okay, and this is not apex forming, if this left ventricle I have. So this is one of the hypoplastic left heart syndrome, and if I take you here, this is the aorta, and it's very small, okay? This is descending aorta, ascending aorta, so the way it goes is small. Now again, we go more and more, we see very small aorta, and then we take the ratio between the aorta, which is very small, and pulmonary artery, which is very big. So the RV is very big, the right ventricle, of course, and the pulmonary artery is also very big because the other ventricle is hardly in action to be used. So we have RV big and pulmonary artery big. We have LV small and aorta small as well, okay? Now, this is one of the cases that I've done, and this is an IVF with a triple pregnant. Them had a hypoplastic left heart syndrome. And of course, just very simple, you do the 2D and you find one big ventricle. You cannot say, tell the mother, I have to refer you to the fetal cardiologist. One of the objectives of this talk is to know when to refer and what to refer. And if you of this patient, you will find a very small ventricle. So we call it, other ventricle is there, but it is very small and not functioning. So this is what we call hypoplastic left heart syndrome. Hypo means so it is small, and the other one is there. We're always made to have two ventricles, but one of them is not there or not. This is the single ventricle physiology, okay? So we just finished the hypoplastic left heart syndrome. I'm going to take you to another case, which is the fallow, which is the rubaiyat fallow. What we have here is the RV and pulmonary artery. Tetralogy is 4, fallow is the guide. So what do we have in tetralogy? We have 4 anomalies: a large VSD and a small pulmonary artery, and RV, hypertrophic, and overriding aorta. What does overriding mean? It means it overrides the 2 ventricles, like a trouser, like a pantalon. So one is here and one is there. So this is what we see here. So mainly tetralogy fallow is easy to diagnose, but if you only do the 4-chamber, you can miss, and this is how other colleagues miss the diagnosis if you are in a hurry as well. And if you do lax, then you can get the pulmonary artery as well, and then you know that there's a VSD. If you don't go up to the great vessels, you will patients for a VSD, but in fact, it's more complex. You have a VSD, Postnatally, you can wait a little bit for surgery, but if you have the triage of fellow, the assessment is totally different and the counseling is different. This is a case. Her mother was a doctor, and she came. This is what I was telling you, that she was referred as a VSD. In fact, if you see that, once you see this overriding, so the intraventricular septum, you see the aorta here, and this is always think of either pulmonary stenosis or pulmonary atresia. And then you look here at this one here, the valve is very small. In utero, diagnosis of stenosis is not easy because gradient. We just follow the diameters, and sometimes you get the gradient. So this is also a third problem that we have here. I think I have to stop very soon. Ventricular septal defect, which is the whole endoventricular septum, and we have different types of defect. We have what's called outlet, we have inlet, we have membranous, and we have muscular. So outlet near the great vessels, inlet, mitral tricuspid valve, membranous near the septum, near the membranous part of the septum, muscular near the muscular part of the septum. So majority of ventricular septal defects that we have to know. And of course, if I have muscular, then what we have to answer that it might close in utero before delivery. So I had a case where I diagnosed muscular VSD, and I referred her back to the hospital, and 32 weeks, the obstetrician opted to do cesarean because she was worried, and she was not very aware of cardiology. And then I 2 weeks before delivery, she delivered her at 34 because she was worried. That was the myth or misconception of having congenital heart, have a heart rate above 200. You can have a heart rate below 100, so one is tachycardia. So what we see here, we see that this is a flickering heart. The commonest is supraventricular tachycardia, and the commonest of them respond to digoxin. Now, some of them don't respond to digoxin because it's more complex, and we have to give flecainide or procainamide, and we have to admit them to the hospital. I treat this properly. Within a week, everything is under control, and I don't have to get the baby out. But if I miss, I can have cardiomyopathy and have hydrops, which happened as well. So I would give we give the mother digoxin at a bigger dose than the other cardiologists. So as fetal cardiologists to give the treatment, the doses are much bigger. The other cardiologists will be scared because they give 250 micrograms a day. We give 2 grams 4 times a day. And so you will have to be responsible for that. You have to do an echo. You'll have to put the patient under surveillance. You will have to do blood levels and so on. But alhamdulillah, things go very well. And this is how they do the ECG for the fetus. It's called fetal magnetography. And because we don't have an ECG on the fetus like we do with a postnatal where we put 12-lead ECG on the baby, but no, we just put it on the mother. And of course, what we do, we are inferring that this is an ECG, but in fact, it's not an ECG. And I'm going to end my talk by a very beautiful indication for fetal echo, which is the focus, abnormal focus, either right or left ventricle. We tend to get a lot because this is a soft marker for trisomy 21. And what we do here, we do a stick and we see where the focus is, and we want to make sure that we're not mistaking it for anything else. And really, it's very benign. But if I have other soft markers, as obstetricians will probably consider this soft marker. This is non-compaction of the left ventricle. So you have 2 types of fetal hydrops and 2 etiologies of fetal hydrops, but the definition is the same. Different. Now, this is the mother that came to me with abnormal heart, and she's young, Caucasian, Jordanian, and first baby, and we saw this here, and we were worried. What are we seeing? We're seeing a mass between the 2 ventricles. We're seeing AV valve regurgitation. And here, what we saw in the 3D, we saw multiple masses, and we saw like a ball obstructing the left ventricle. So tumors of the heart is rhabdomyoma, and it is called tuberous sclerosis postnatally. So we kept the baby in utero. She was delivered, and after delivery, also baby was fine. But 48 hours, of course, this is not a static obstruction of the aorta. This is a dynamic of the aorta. So at 48 hours, she went to OR, and they took this ball, sent it for pathology, and came to be as rhabdo, and baby's about 5 years. This is postnatally. unfortunately, since it's autosomal dominant, the father divorced the mother. He didn't want to have any more babies of the sort. And I think this is the end. If you'd allow me, give me 1 second just to invite you to the Fetal Gulf Heart Group. It's